right, we're talking about the cardiovascular system. Part two is the coronary circulation, how the heart muscle gets fed. So the things we're going to break down, talk about the anatomy, the coronaries, coronary arteries, coronary veins, the physiology of how that oxygen is delivered to the myocardium, and how that only happens during the diastole, during half of the cycle, cardiac cycle. And then I'm going to go into vascular disease and plaque formation and a couple patient examples. Okay, so this is a schematic of the right side and the left side of the heart. So remember, the heart is a double pump. On the left side of the heart, it's the high pressure system pumping oxygenated blood through the aortic valve to the rest of the body. On the right side, it's still a pump, but a significantly lower pressure pump, sending deoxygenated blood that comes from the body to the lungs for oxygenation. And it's right at this point, at the base of the aortic valve, that blood enters the coronary circulation to the left main and the right main coronary arteries. And this only happens when that valve is closed. It's only when the backflow of blood goes into those coronary arteries that oxygenation occurs to the coronary arteries and to the myocardium. The anatomy, looking at a couple different views. The top figure is the anterior view. So this is actually how your heart is sitting in your chest. So if you get stabbed in the chest, most likely the stab is going to go into the right ventricle. At the base of the aorta is coming out these two major arteries, the right coronary artery and the left main. So the right coronary and the left main are coming out. And this bottom photo is showing the base of the aorta and the left main coronary artery feeding the majority of the heart. And the left main splits into the left anterior descending that feeds the intraventricular septum, majority of the left ventricle, and then the left circumflex that comes around. So as this oxygenated blood flows into the coronary arteries, it starts feeding the myocardium at this place, at the capillary network. So the arteries and the veins are conduits. They're carrying the blood, but the actual oxygenation and exchange of gases happens here at the capillary bed. And then that deoxygenated blood flows over into the vessels, into this holding pen, the coronary sinus, that takes blood and dumps it into the right atrium because it's all deoxygenated. It wants to dump it into the right atrium so that it gets fed into the lungs for oxygenation. So basically, coronary arteries fill, oxygen exchange happens at those capillary beds in the myocardium, exchanging carbon dioxide and metabolic waste, returning to the coronary sinus, and then that venous blood is going into the right atrium. First question, during diastole, are the aortic and pulmonic valves open or closed? So this is your figure to look at systole and diastole. Systole is when the ventricles, both ventricles, are squeezing, contracting, and at that point, the aortic and pulmonic valves are open. And the second figure over to the right is during diastole. So your right answer is those are closed during diastole. During diastole, having the diastolic filling of the left and right ventricles, and also filling of the coronary arteries, because the backflow, this blood that's in the aorta, is starting to come backwards It can't come into the left ventricle because the closed aortic valve. And so instead, it fills these coronary arteries. So blood fills the ventricles and the coronaries during diastole. So what this means, if the heart is working very hard and fast, you're not going to have diastolic filling time. The heart muscle is going to be deprived of oxygen. And that's why tachycardia or rapid heart rate is very bad for a person with coronary artery disease. And coronary arteries disease, what that is. Let's go through that. Some terminology. Hear the words angina, MI, myocardial infarction. Angina is where it's a temporary ischemia, where there's a temporary lack of oxygen. So oxygen-starved tissue. This is a reversible state. So someone can take their nitroglycerin, it dilates their arteries, and they can get better blood flow. For a heart attack, otherwise known as an MI or myocardial infarction, this is where there's actually an obstruction to blood flow, and the tissue, the myocardial tissue, is actually dying. And this does require emergency treatment. If you can get to the cath lab and get this open, they can either remove this clot, put a stent in, or do an emergency bypass graft to protect the myocardium from dying further. So this is what usually happens with actual heart attack. There's plaque, and the plaque that's in the artery has a cap to it. And if this gets ruptured with like turbulent flow of blood, spasm of hypertension, something like that, a clot forms. That irregular surface attracts platelets, and platelets start the coagulation cascade. And that clot is what blocks off, is the terminal event for blocking off the artery. What is generally the immediate cause of death when someone has a heart attack? Is it A, weakened heart muscle, B, arrhythmia, which is an abnormal heart rhythm, or C, heart muscle rupture? We're talking about the immediate cause of death. And the answer is arrhythmias. They get an abnormal heart rhythm. So a heart attack, this is like the worst that can happen with a heart attack, is you go from normal sinus rhythm, this upper rhythm on EKG strip, to ventricular tachycardia, where all these areas of electricity are firing off at the same time. It's a poor pump function. And so this is the immediate cause of death. These are arrhythmias. But these are also other complications from a heart attack, is having poor heart function. That's where you hear the term cardiac cripple. So this is the take-home message, is that if you have someone that you suspect is having a heart attack, you need to get a defibrillator ready immediately, because adding external electricity can switch this from V-tach back to sinus rhythm. So let's go back to what causes plaque formation. Is it A, high cholesterol, and B, rise in blood pressure, or smoking? That should be C. So what is the first thing that's needed to cause plaque formation? The answer is the rise in blood pressure. I'll show you the physiology of that in the next slide. This is a cross-section of a vessel of an artery, showing this endothelium. These are these flat cells that line the inside of a arterial wall. And this is like the smooth muscle. So you get a tear in this endothelium, and that happens with a turbulent blood flow, and that happens with an elevated blood pressure. And then what happens is that you get these inflammatory cells start to move in. The inflammatory cells are a type of cytokine that start inflammation. Macrophages are a type of white blood cell, and they get pulled into inside this endothelial crack and start turning into what they call foam cells. And then with this crack, they start pulling in LDL cholesterol. But the point is that LDL is within that plaque, but it is not the primary cause. You have to have all these other things happening before LDL gets pulled in for plaque formation. So this is my little graphic depiction of how all this happens. A longitudinal image of showing a crack or a tear in the endothelial lining of a vessel. And then these macrophages, those white blood cells, cross, they turn into these foam cells. And then these cytokines, which are depicted by the letter C, get in there. They bring in low density or LDL lipoproteins, that bad type of cholesterol. So there's a lot going on in plaque formation. But the first thing is that tear. The next thing is having inflammation in the blood that pulls in LDL and cytokines and starts forming this plaque. Now notice that LDL is higher in diabetes and obesity. So all of these things are happening all at once. This is just a review, reminding you of what total cholesterol is. It's made up of HDL, that's otherwise known as the good cholesterol, LDL, the low density lipoproteins, and LDL is around in the bloodstream because it's on its way to taking cholesterol to cells. Because cholesterol actually is needed in cellular growth, in like cellular membranes. So it's important for the body to have that cholesterol, but not in massive amounts. HDL is real small, and it's taking the excess cholesterol back to the liver. So that's why it's great to have a high HDL, because it removes the excess cholesterol in the bloodstream. The risk factors that cause inflammation, which turn around and cause heart disease and vascular disease, are all of these factors shown in this infographic. So it's obesity, smoking, high blood pressure is huge, of course, diabetes, lifestyle, and of course, aging increases the risk for cardiovascular disease. And then the demographics, men are much higher likelihood for developing heart disease, and notice women after menopause. Let's look at what happens with obesity. Adipose cells, of course, are actually, in lean states, are actually helpful. Lean adipose tissue releases anti-inflammatory cytokines. The resistant leptin's great, it suppresses the appetite. But with significant weight gain, those adipose tissues start to outgrow their blood supply. And these macrophages that are within your tissues get activated, and they're as white blood cells to clean up old debris. So old, dead, dying tissue cells that can't be fed because they've lost their blood supply get activated, and that necrosis starts to release pro-inflammatory factors. And TNF alpha, IL-6, nitric oxide are pro-inflammatory factors, and that causes that cascade of inflammation. So for plaque formation, the bottom line are two things: high blood pressure, and not just high blood pressure all the time, but bouts of high blood pressure that you get under periods of stress. So it takes more than cholesterol, it takes high blood pressure, and it also takes inflammation. Okay, so next question: is there a correlation between dental plaque and coronary plaque? Are you at a higher risk for heart disease if you have dental disease? Would you guess no correlation, or yes, there is a correlation? And of course, the answer is yes, there is a correlation. Because dental disease causes that film of bacteria, it causes gingivitis. Anything with itis is inflammation. It allows bacteria to get in the bloodstream, and then you get an inflammatory response, more white cells in the bloodstream, and all you have to have is a disruption in the lining of your arteries, and then you start that inflammatory response. So the people that are particularly at risk are people, of course, with hypertension and diabetes. All right, next question. How does nicotine affect arteries? Does it increase plaque formation, or does it constrict arteries? The answer is it constricts. It's a very potent vasoconstrictor, nicotine. So it's when you see these showing this unborn baby with the smoke, it's actually the nicotine that is so dangerous to the unborn child. So it gets this vasoconstriction. This is a depiction of a vessel that's vasodilated, and then to the right showing vasoconstriction, because arteries have a lot more smooth muscles than veins. So they're able to constrict down. So with the constriction, you'll see a significant reduction in the amount of red blood cells that can deliver oxygen to the distal tissues. And that's especially true for things like fingers and toes, coronary arteries, small vessel disease, kidneys, kidney disease, and especially what we're talking about for pregnancy is this tiny small vessels that are needed for the placenta. Placental insufficiency is what it's called, and the babies get inadequate blood flow, get an inadequate nutrition, and what they end up very small, and they get this lack of good blood flow through the placenta. I'm going to go through just a few case examples for patients in the operating room. These four are these were the listing. These were my cases for one of the days when I was working in vascular surgery. One was called an arterial venous anastomosis. That's when you're combining the artery and a vein to create a shunt for putting a patient on dialysis. The other is a femoral popliteal bypass for arterial occlusion. So this is a person that has plaque in the femoral artery, and we need to create a bypass around that obstruction. Then another case was a foot debridement, toe amputation, vascular insufficiency, and the last, that brachial artery embolectomy, a blood clot that got stuck in the brachial artery of the right arm. Oh, this is the foot debridement. Lost a couple toes, tissue that's dying that won't support normal tissue. It's a 57-year-old woman, heavy smoker, and most likely she's got coronary artery disease as well. But what she's showing up with is these loss of blood flow to tissues and losing toes because of it. The next was the femoral bypass. So this is a 63-year-old, high blood pressure, diabetes, and plaque that's formed an obstruction in the femoral artery. So this is the thigh that's open, and this is a graphic depiction of how there's the blockage, and then this creation of detour routes, so a graft gets placed. So they'll take a vein, the patient's own vein, and sometimes those are the best, but you could also use synthetic graft material to form a conduit around. So it's a collateral circulation around that obstruction. All right, let's do a case scenario real quick. So heart attacks, this is just scenario that's going to come up with a question for you. You have a woman and a man. They're both the same age. We're going to give them fraternal twins because we want them to have the same genetics, the same demographics. So they've been eating the same way, living the same lifestyle. And they both have heart attacks on the same day. Who is significantly more likely to die from their heart attack, the man or the woman? And the answer is a woman, for a number of reasons. First, let's go through the collateral circulation. Just like with bypass grafting, your body is very smart. When it starts to notice that there are plaque developing, the arteries are insufficient, over time they start to develop their own collateral circulation. And this can happen if that plaque formation is very gradual. And that's what you'll see in a man. In the woman, they're actually being protected with their estrogen premenopausal. So they don't have the need to form this collateral circulation. Okay. So this is a graphic depiction of the collateral circulation that's developing slowly over time. So these alternative routes around this obstruction. So with women, they have menopause, their ovaries quit, estrogen levels fall, and they don't have time to develop this collateral circulation because the plaque formation starts to develop very quickly with the loss of estrogen. So in a heart attack, women are more likely to die because they're not going to have this. They're not going to have this collateral circulation, and also women get diagnosed much later than men. Women, for whatever reason, have different symptoms. They'll have sleep problems like a month before they actually have their heart attack. They'll start having excessive fatigue. Men get the typical chest pain, radiation down the left arm, jaw pain. Women might just present with vomiting, indigestion, nausea, and like I mentioned, fatigue. So this is actually a true story. This is a 30-year-old female. She had type 1 diabetes since childhood. So she had an increased risk with her, actually she was poorly controlled diabetes. So she was developing plaque formation. She presented with upper GI symptoms. So she had a lot of nausea, vomiting. She was complaining of symptoms of reflux, heartburn. she was being worked up for what they suspected was stomach problems. And so they had her down in the radiology suite. And in the radiology suite, under doing a barium enema, she had a full cardiac arrest and died. So, what would have been the cause of her? What would have been the final cause of death, or what initiated her cardiac arrest? Was it heart muscle fatigue, a fatal arrhythmia, or hypoxia, low oxygen? And arrhythmia is spelled wrong, by the way. It looks wrong. Well, the answer is a fatal arrhythmia. All right. So summary coronary circulation showing, this is showing those two main coronary arteries coming off the base of the aorta. So remember, the oxygenated blood is feeding the heart through those coronary arteries. And this is a good image off to the left of the screen, showing the ostia, the opening. And this opening, you can't see it on the other side, but when these cusps are closed, the backfill of blood allows oxygenated blood to fill those coronary arteries. So you have to have a nice, good seal of your tricuspid valves. This is your aortic valve, but it's a 3-leaf valve, 3 leaflets. And this flow only occurs when the aortic valve is closed, and that happens during diastole. And this picture is from the Anatomosh table. So number 1 is the coronary arteries. Number 2 is the aortic valve. In situations where you can have reduced coronary blood flow, is reduced diastolic filling time with a very rapid heart rate, aortic valve problems. If you don't have a good leaflet, if your leaflets don't close well, like severe aortic regurgitation, you can have reduced coronary blood flow. And of course, coronary plaque. And then also I mentioned here is coronary spasm. That's something that's not quite as common, but that can be a cause of a heart attack in a patient who's very young that doesn't have plaque formation. Okay, I just want to mention that specifically losing your aortic valve, if this happens gradually, you can compensate up to a point, but with acute loss of your aortic valve, it can happen like in Marfan syndrome. You can not have any flow of blood into the coronary arteries. You can also have acute pulmonary edema, where blood flow is going into the lungs, and that results in very quick hypoxia and death. And then to recap, coronary artery disease, plaque builds up. Angina is when it's hard to get through the blood flow, so you get ischemia. And a heart attack is actually when there's a clot formation or something that obstructs blood flow. So to prevent a heart attack, take 1 aspirin every day. Take it out for a run, take it to the gym, take it for a bike ride. So exercise improves improves or reduces the risk for coronary artery disease. The reason we're talking about an aspirin in particular is that when you suspect that someone is beginning to have a heart attack, that aspirin stops that clot formation. So it keeps the clot from extending and getting much bigger. So it reduces the reduces the area of clot formation, so it may protect some of the myocardium. And just a reminder, plaque formation begins with that disruption of the endothelial lining. So you have to have a tear in the wall, inflammatory cytokines. So if an inflammatory state increases your risk for plaque formation, elevated LDL makes the plaque bigger. And this is showing just a depiction of how plaque formation is initiated. So inflammation with risk of weight gain increases inflammation. With the macrophages getting pulled in, oxidative stress, and all of that happens in the presence of cardiovascular disease, diabetes, cancer. And then lastly, men versus women. Women are more at risk, and they have those signs that are considered, the term is unique. So nausea, epigastric discomfort, jaw pain, where men have the classic signs. And that's it. Questions, please leave comments. The PDF is going to be in a link that you can find in the my Google folder.